All right. So firstly, I would like to extend a warm welcome to our two featured speakers, Danny Renouf and Dr. David St-Jules, who are joining us for the professional breakout session. It's going to be a really informative and fun hour and a half, and I know that you're going to leave the session with new ideas to take back to your practice and just continue to evolve like we do. Our first speaker is Dr. David St-Jules. He is currently an assistant professor in the Department of Nutrition at the University of Nevada in Reno. He has done extensive work in the area of dietary determinants of complications in people with kidney disease. And with his many novel ideas, we are truly privileged to have him here today. And he will also be a concurrent speaker tomorrow. So I hope you will be able to join us for both. Today's session is going to be a deep dive into the etiology-based renal diet therapy with a focus on hyperkalemia and protein energy wasting. I encourage you to read through some of Dr. St-Jules' publications. They're very vast, and you will definitely learn a lot. And I am now going to hand the platform over to him.
All right, thank you very much, Karen. Appreciate that, and welcome everyone. I'm glad to see everybody here, and the more faces I can see, the better. So that's fantastic. I always appreciate when I'm able to see the people. And in terms of my presentation, I'm going to go ahead and share my screen right now. Feel free to jump in. Feel free to interrupt me. I have not prepared like a presentation that was intended to be sort of delivered for the entirety of the time. My hope is that I'm going to give you a bit of a primer to sort of generate some ideas so that we can have some conversation and leave more time open to you to ask questions. But I will go ahead and hit present here. Can everybody see this okay? A thumbs up. Excellent. Okay, good. Okay, so I'm going to go ahead and, okay, somebody admitted Daisy. That's good. All right, I'm going to minimize this so it's not in my way. Okay, so this is our breakout session. Again, my name is David St-Jules, and there's a nice picture of the University of Nevada, Reno. So in terms of the objectives and conflicts for this presentation, so I'm going to be reviewing the dietary pattern for CKD very briefly, the one that's sort of the traditional pattern that's recommended. Then I will be spending a little bit of time exploring the dietary and non-dietary determinants of hyperkalemia, hyperphosphatemia, and protein energy wasting. And as was sort of noted by Karen, I'm going to be primarily focused on hyperkalemia and secondarily on protein energy waste. I'm not really going to spend much time talking about hyperphosphatemia, but again, this is your session, this is your time. So if you wanted to, if you had questions about hyperphosphatemia, I'm more than happy to get into that conversation as well. In terms of conflicts, I just have one to report. I had an investigator-sponsored trial with Dr. David Goldfarb from Ellipsa Inc., who are the makers of Patiromer, which is a potassium binding agent. I'm not going to be discussing potassium binders today, so I don't think that conflict will come up. But you might have questions about binders. So in terms of the traditional renal diet, so the traditional diet is based on what I call a nutrient-based approach. And some of this material will be a focus of tomorrow's presentation, but I just wanted to sort of use it again here just to introduce you to it. So my feeling on the nutrient-based approach is it sort of looks something like this. You find a particular diet-related complication like hyperkalemia here. And then you find the problem nutrient. And then what you do is you establish how much the person should eat in order to avoid that complication. And then that gets translated into food. And that's ultimately what we recommend to our patients. And this is a rough outline of the diet for dialysis. It's very similar between the dialysis and non-dialysis. One of the big differences would be the additional protein in the hemodialysis population. But a lot of the nutrients, which are represented here on the right, and the corresponding effects on dietary balance and variety in terms of the dietary pattern are sort of shown here. So you can see if we look at the different food groups, so in the fruit and vegetable group, one of the main recommendations is to limit high potassium fruits and vegetables. Within the grains group, the recommendation is to, and again, this is evolving, there's different opinions on this, but the traditional recommendation is to avoid whole grains because of the higher phosphorus content. Limit dairy products, both because of their potassium and phosphorus content. That's just a general limitation, not a specific recommendation within it. And then within the protein foods group, there has traditionally been a focus on avoiding the nuts, seeds, and legumes, and then consuming a lot of protein from the animal-based sources, so meats and eggs. And again, avoiding the plant-based sources is about avoiding the potassium and phosphorus, whereas the need to have protein with every meal is in order to meet the protein requirements. So that dietary pattern, that whole approach has within it a variety of assumptions. And so I'm going to go through some of those assumptions. The first one is causality, and this is going to be the main one I'm going to focus on because a lot of my research is based on determinants. And so one of the assumptions is that this is the most important thing in terms of causing that diet-related problem. So in the example from before, hyperkalemia, the assumption of giving a patient a low potassium diet is that dietary potassium intake is the most important causal component of hyperkalemia from a diet perspective. So it prioritizes that particular nutrient as the main causal factor. It assumes equivalence. So within the way that the guidelines are set up, it does not distinguish between the differences in potential bioavailability, for example, of potassium and phosphorus from plant versus animal sources would be a good example of a non-equivalence. It assumes acuity. And what I mean by that is when you look at the way that foods are classified as high phosphorus or high potassium, the way that they do that classification, the denominator is servings. So what they look at is how much potassium in a typical serving. Well, that assumes that your risk from that particular nutrient is acute, that consuming too much at one time is problematic. If we think about potassium, that's actually very true. If we think about phosphorus, however, though, it's not the acute exposure to phosphorus that matters, it's the chronic exposure. So it's how much phosphorus you consume overall in your diet because it's more of an accumulation. And so it doesn't necessarily make sense, for example, to classify nuts as a high phosphorus food because the correct denominator for phosphorus would be calories, not servings, right? Because it comes down to how much phosphorus you eat in the overall diet, whereas potassium, the amount per serving is important because it's the acute toxic load of potassium that causes hyperkalemia. The final thing that this renal diet sort of assumes is that what I call sort of adherence translation, that at the end of the day, when you give a person that overall diet, so you put them on the low potassium diet to manage hyperkalemia, that their health outcomes will improve. And that's not really been well demonstrated by any sort of research trial, short or long. That's just an assumption that's sort of been built into the model. But we do know that there are a lot of diet-related complications in this population. And so to sort of assume that, well, we're managing hyperkalemia, therefore the net benefit is to the patient, that may not necessarily be true, particularly when you look at the overall dietary pattern. It's not exactly a healthy one. So I said I wanted to spend a very brief time going over some of the interesting mechanisms of potassium homeostasis and balance as a way of sort of understanding hyperkalemia a bit better. And so what I have here is a little potassium kinetic model, because when I think about potassium and disease, I break it down into sort of the acute meal exposure and then versus the overall dietary exposure, how much you consume overall in your diet. So what I'm talking about here is potassium kinetics. I'm talking about what happens when you eat a high potassium meal. And just to orient you, this intracellular fluid, we know that the intracellular compartment is full of potassium, much higher in potassium than the extracellular compartment here, which is represented sort of by the blood. This is just sort of a muscle group here. And we do know that if a person has functioning kidneys, they're going to be removing potassium primarily through the urinary route. And this is our hepatic portal vein, in case you're wondering what this is right here. So this is bringing blood from our digestive tract. So we do know, how is this gradient maintained? This is a very severe gradient. How is that maintained? It's maintained primarily by the sodium potassium ATPase. And one of the things that I'm very interested in terms of my own research is what affects the sodium potassium ATPase, because this is the master regulator of internal potassium balance. And so when we look at the factors that affect sodium potassium ATPase, as one of the important determinants of the expression of these particular proteins is actually how much potassium you eat. So a patient who eats a very low potassium diet will have a downregulation of these transport proteins. A person consuming a high potassium diet will have a greater expression of these transport proteins. And this has been demonstrated both, primarily in animal models. Actually, what they found is that when they put these mice on a low potassium diet, they gave them a large potassium bolus that killed them. However, if the mice were maintained on a higher potassium diet when they had a high potassium bolus, the same high potassium bolus, they did not die. So essentially what it does is by having an increased expression of these sodium potassium ATPases, you have improved postprandial potassium tolerance, which is important because that's one of the things that becomes dysfunctional in CKD. Another thing that increases the sodium potassium ATPase, which is another part of my research, is physical activity. So when you work out, potassium leaks out of the muscle cells and into the extracellular fluid. This is just something that happens with muscle contraction. And so what happens is that disrupts the sodium gradient, and it sort of causes a transient hyperkalemic state. And it can be quite dramatic, the movement of potassium out of the cell. So what happens? In order to protect the patient, it increases, when you work out, it increases the expression of sodium potassium ATPases, which may, again, through a similar mechanism, help to control serum potassium levels, particularly in the postprandial state. So I just wanted to sort of give a brief discussion about that, because I think that's one topic that we could discuss today. In terms of the hepatoportal vein, we know that there's blood always flowing through there. So there's always some basal level of potassium. And we do know that in the kidneys, there's always some kaliuresis. There's always some potassium being removed. This is representing a normal person. This is not somebody with CKD yet. So what happens if you eat a 550 milligram potassium bolus? And again, starting with the standard healthy person, then we'll talk about how that's different in CKD. So a standard healthy person, what happens is there's actually a feed-forward mechanism that they haven't fully elucidated. So what happens is we know that you have an increase in kaliuresis even if your blood potassium levels don't change. So something is being detected in terms of the dietary potassium intake, and it's signaling to the kidneys to start increasing the release of potassium in order to anticipate the bolus. And what we see is actually in a normal healthy individual, their blood potassium levels don't change postprandially. And I'll show you a picture of that. So anyways, this feed-forward mechanism goes to the kidneys and tells it, by the way, there's some potassium coming in, increase kaliuresis in order to avoid this bolus ending up in the blood. And so the other thing that happens is, assuming this is a mixed meal, you're going to have something in there that's going to stimulate insulin. And what insulin does is it actually increases the expression of those sodium potassium ATPases, and that facilitates postprandial uptake of potassium. So this is in a normal healthy individual. So normal healthy individual, no change in potassium when you eat a potassium bolus if it's accompanied with carbohydrate or amino acids to stimulate insulin. Now, in CKD, there's a loss of kaliuresis. You lose the ability to have that feed-forward protective mechanism because you don't have that connection there. And so what ends up happening in CKD, you do maintain external potassium balance. So although the kidneys lose the ability to eliminate potassium, throughout a 24-hour period, you maintain external potassium balance primarily through the bowels. And so this is another thing that I think is an interesting thing to discuss, which is the bowel secretion of potassium. So it increases roughly threefold as you go into end-stage CKD, and really almost up to 4 grams a day can be removed through the bowels. So it does seem as if in these patients, they can maintain external potassium balance as long as they have adequate stool output, even though they lose this kaliuresis. However, in the postprandial state, they're going to have impaired potassium tolerance because even though this is great, this bowel mechanism is great in terms of maintaining long-term potassium balance, it doesn't have the feed-forward mechanism. It cannot respond to a potassium bolus. It doesn't adjust its intake in response to dietary potassium. The strongest determinant of stool potassium output in CKD is actually how much stool do you put out. Okay. So this is just a graph showing what I was describing previously in the slide before. And so you can see what they did is they collected urine before and then 3 hours after a large potassium bolus. And they did this in individuals with varying GFRs. And what you can see is an individual who's got a normal kidney function, their eGFR is in the normal range, they can increase their potassium output in their kidneys roughly 5-fold in response to this bolus. Somebody with very low eGFR, they're almost at their capacity at that point. They cannot modify and so what that means is that this happens. So I'm just going to pull this up here. So this is what it looks like when you bolus a patient with hemodialysis or a control person with either potassium chloride or potassium chloride with glucose. So this graph shows us both the difference between a hemodialysis patient and a general healthy control. You can see that consuming carbohydrate with, glucose with potassium chloride, they have a postprandial kalemic response, whereas a healthy individual, there's no change in serum potassium. And that's, again, because of that feed-forward mechanism that's not only helping to, not only do you have potassium uptake into the cells, you have this increase in kaliuresis, which is helping to remove potassium. The other thing that this graph shows us is that glucose is really important. So if you have something that is high in potassium but not insulin stimulating, then you're not able to activate those sodium potassium ATPases, which means that the potassium gets stuck in the blood. There was actually a study where they, it was Stearns was the author, they infused IV infusion of potassium into a type 1 diabetic who was withheld insulin. And you actually see potassium accumulated in the blood, almost like a one compartment model. So it just accumulates until they gave them the insulin to actually get it into the cells. So anyways, this occurs postprandially. So you have to be aware that your patients, if they eat a large enough potassium bolus, will experience a postprandial kalemic rise. And the interesting thing is it doesn't matter what your baseline potassium is. Even people who have normal fasting and normal pre-dialysis serum potassium concentrations have impaired potassium tolerance. This will occur even though it's unseen. So something to sort of keep in mind that is occurring. However, and this is where the bulk of my work is actually located in, there's no association between dietary potassium and serum potassium. So this was a cohort of 140 hemodialysis patients. This is their pre-dialysis serum potassium levels. You can see it's not associated with potassium intake. And this has been replicated quite a few times now. It does not appear as if dietary potassium intake is associated with serum potassium levels, either in the pre-dialysis or the fasting state. And there's a variety of other evidence against. I'm not going to go through all of these, but vegetarianism is not associated with hyperkalemia. Very low nitrogen diets, which were lower in dietary potassium, increased serum potassium. So that was one of the common complications of those very low nitrogen diets, even though they were very low in potassium as well. There was been a couple studies where they've given fruits and vegetables to patients with stage 3 or 4 CKD, and outcomes have been very positive in those studies without any indication of hyperkalemia risk. And then finally, this is just what I'm showing here. They're just not associated with each other. So how do you reconcile that? How is it that dietary potassium causes this postprandial rise in serum potassium, but they're not correlated chronically? And the reason is that main assumption, that causality assumption, there's actually a lot of things that determine blood potassium levels. And this graph just sort of highlights some of them. And this is just a summary graph that, and again, I think from here these are topics that we could discuss, but one of the things that's going to happen in terms of determining your blood potassium levels is obviously the more potassium you eat, obviously the more potassium that you eat, the higher the postprandial kalemic rise in terms of a one-off. If I was to just take a hemodialysis patient and give them 1 gram versus 2 grams of potassium, I would expect their blood potassium levels to go higher with the 2 grams. However, as I mentioned, there's this concept called adaptation. People who eat high potassium diets have greater expression of the sodium potassium ATPases. They are better able to tolerate a postprandial bolus or a bolus of potassium in terms of their kalemic response. The other thing that I mentioned briefly was that we have an increase in stool output of potassium in CKD. So one of the questions that that's ongoing, and I'm actually doing a research project on this, I'll tell you about it briefly, is the question of fiber intake. So I mentioned the most important determinant of stool output of potassium is stool output. Well, what determines stool output? Fiber determines stool output, actually fairly predictably. And there have been studies, there was one study in 76 by Cummings, where what they found is that they gave them whole grains, and it increased the fiber intake of the diet like 30 grams. So it went from 17 to something like 47. And what they found is that even though whole grains do have some potassium, so it was an additional 500 milligrams of potassium in the diet, the stool output of potassium increased threefold. And so we do know that if fiber is consumed in the diet, And we do know also that constipation is associated with hyperkalemia and CKD. I should mention that. But we do know that increasing fiber intake will increase potassium output in stool. The question is, does it go into the blood and then get removed through the colon? Or is it actually blocking the bioavailability of potassium? And so that's a research study that I'm doing right now. So what I'm going to be doing is I'm going to be taking 10 diabetic and 10 non-diabetic hemodialysis patients. I'm going to bring them in on a non-dialysis day in the middle of the week. I will, in a fasted state, bolus them with orange juice in order to cause postprandial hyperkalemia. And then I'll bring them in a week later and do the exact same thing, but with fiber. And so what we're looking at is we're going to examine the postprandial kalemic response to see, does fiber blunt the postprandial kalemic response? Because if it does, then that means that it's actually blocking the absorption, which would be great because that means that we can protect against postprandial hyperkalemia with a very simple supplement or dietary modification. If it doesn't, that means probably that the way that potassium is increasing stool output is probably through more of a colon-related mechanism, which means that the potassium still got into the body, which means that unfortunately, high potassium sources of foods that are high in fiber, you may still get that postprandial kalemic response, unfortunately. Another dietary factor that's really important in terms of determining potassium balance internally is acid load. So we do know that high potassium diets are low in dietary acid load. And we know that metabolic acidosis contributes to hyperkalemia. And it does so by creating sort of an exchange between the intracellular and extracellular compartment, pushing potassium extracellularly. And then the final thing I just wanted to mention is insulin resistance, which is just interesting because it is associated with hyperkalemia, although the mechanisms involved there are not well understood. And it's not clear if you can reduce somebody's insulin resistance with diet, does that in turn lower their risk of hyperkalemia? So that has not been established. It's just sort of an association. So here's just some ideas in terms of potassium that we can talk about. And then the other thing I just wanted to sort of bring up, because I think it's another interesting area of conversation, is malnutrition. And so this is a very simplified model of malnutrition. And it's a model that I think, unfortunately, ends up being used too often when we approach a patient that has malnutrition. So obviously, when we're thinking about malnutrition, we're trying to shift the equation of protein anabolism and catabolism. We want more anabolism and we want less catabolism. And so one of the things that we can do to promote protein anabolism is make sure that there's adequate enough protein, right? So you have to consume enough protein. So that'll be very important. Well, you can't consume enough protein unless you consume enough food. So obviously energy intake is important in terms of determining protein intake. And then also energy has an indirect effect on protein anabolism, catabolism. A patient in negative energy balance will have a very, very difficult time getting into anabolism. So we even see this in healthy individuals. Healthy individuals losing weight, lose muscle. They don't just, even if they go on a high protein diet, they lose muscle. And so negative energy balance, unfortunately, it causes hormonal changes, just makes it very difficult to get into anabolism. So that's something to pay attention to that's really important. But I would add to this model a little bit more and sort of say, okay, well, we do know that patients with CKD, they eat protein. When you look at the percent of calories from protein, it's similar to healthy individuals. If they actually ate the amount of calories they're supposed to, in most cases, they would be getting enough protein. So one of the biggest problems in terms of what's causing malnutrition, I think, is a lack of energy intake. And I think there's a few reasons why we are in slight negative energy balance. One is that patients with CKD have a lot of anorexia and early satiety. And there's a few reasons why they have that. One reason is intake barriers. So we impose barriers on patients. We tell them they can't eat during dialysis. That is associated with a lower intake on dialysis days versus non-dialysis days. We also tell them they can't eat certain foods, and some of these foods are culturally or personally significant, and that can obviously affect appetite if you have a sort of sensory specific satiety there. The other thing that can contribute to anorexia, or probably is the main contributor to anorexia, these patients are not eating because they don't want to. They're not eating because they're not hungry. And why aren't they hungry? Well, that's the milieu. That's the inflammation. That's the insulin resistance. That's the acidosis. That's the uremia. Those are all contributing to anorexia. Those are also having a direct effect on protein anabolism and catabolism. So I think that, unfortunately, this here is tied to the protein intake. And so I'll talk a little bit about that in a second here. I wanted to briefly share with you this study just because I thought it was really interesting. And it hits at one of these points that I wanted to make, which was, so in this study, which is protein utilization, they took CKD patients who had fairly severe acidosis, and it was a crossover trial, and they either gave them sodium chloride or sodium bicarbonate. And what's interesting is you can see here that when they gave them sodium bicarbonate, they ended up in much more positive nitrogen balance. In that same study, blood urea nitrogen was lower when they had the sodium bicarbonate, and so was the urine urea nitrogen. So what that tells us is that the reported protein intake was the same. So what that means is that it doesn't make sense to be in more positive nitrogen balance when you have a lower urea nitrogen and a lower blood urea nitrogen. That would, if anything, these sorts of changes would be associated with a reduction in protein intake. But what's actually happening here is actually they're having greater protein utilization. So without any change to protein intake, we're having reduced uremia and a reduction in urea output in the urine, despite consuming a similar amount of protein. That's because they're using the protein better. They're actually able to utilize it in protein synthesis more effectively, and so they're not having a loss of a protein. And so I thought this was sort of an interesting finding. And so that brings me sort of to this dual burden of protein. So this is not based on data. This is based on actually the DRIs. So that's a wonderful graph on the DRIs that sort of shows this relationship. And this occurs in normal healthy individuals. As protein intake increases, at first we use protein really efficiently. So this is the protein utilization graph. So basically as protein intake goes up, protein utilization eventually, as you approach protein requirements, it will plateau. And so what's happening here, as you increase protein intake, utilization goes down. What happens to proteins that aren't utilized? Well, they're metabolized. They're metabolized and converted into fat, as well as usable energy. Well, when you metabolize amino acids, unfortunately, you create uremia. You have more acidosis, right? So amino acids are metabolized into acidotic products. There's basically metabolic derangements would be expected to increase as protein utilization goes down. And so a lot of these problems that are driving malnutrition are actually worsened by the overemphasis on protein intake. And so that's sort of the question here is, if you keep pushing the protein intake higher and higher and higher, you're not going to push anabolism any further. You're probably actually just going to exacerbate the metabolic derangements and potentially worsen this patient's outcomes. And so this is sort of touching on this idea of, instead of treating the protein so directly with protein, which sometimes it may be protein, absolutely, and that's something to consider, is trying to make sure that the metabolic state is in a way that it can utilize the protein effectively. And I think that this is a problem that is maybe under-recognized. Okay, so in terms of, and again, from here on, I just want to sort of have an opportunity to discuss and ask questions, and I have more slides as well if you wanted to see something else, but I just wanted to touch on a few topics just because I think it's interesting. So in terms of the overall implications, we do know that CKD impairs dietary potassium tolerance. Patients with CKD, particularly after around stage 4, will experience postprandial hyperkalemia if you give them a bolus. Pardon me. However, pre-dialysis and fasting serum potassium are not associated with potassium intake. Well, if you're using a patient's serum potassium levels to identify who's eating too many high potassium foods, they're not correlated, right? So that actually won't work. They're not associated with each other. So that brings into question whether or not pre-dialysis serum potassiums or fasting serum potassiums are an indication of dietary potassium intake. It doesn't look like it, unfortunately. So it becomes very hard to monitor your interventions. And so really what it becomes one of the questions that I have is, so how do you balance avoiding postprandial hyperkalemia with maintaining dietary quality when you're not able to actually assess dietary potassium intake, again, using these biomarkers? You can assess it obviously using dietary assessment. And then in terms of protein energy wasting, obviously, if a person doesn't eat protein, that can affect protein synthesis. However, a lot of the reasons why patients have malnutrition and CKD is because of imposed barriers and these metabolic derangements that are actually contributing to things like anorexia and having direct effects on protein anabolism, catabolism. So I think, unfortunately, more protein may actually make these things worse. And so again, there's that balancing act that sort of how do you figure out getting enough protein without, just adding to the uremia and all these other problems that are sort of contributing. So that's all I really wanted to share. Should I close my slides down? What do you think, Karen? And then just join the conversation?
Yes, I think close your slide down, then we can see everybody. And if you can raise your hands, and then David will select you for your question.
I can't quite see everybody, so.
I see Janet with her hand raised.
Perfect.
Hi, thanks. This is so interesting, and so it could be a really big change in practice for us. I'm just wondering, like, I have clients that are gaining weight, and they're above the ideal body weight, even using a BMI of 27, yet they seem to be, their ureas are low, and the albumins are low. They seem to be not getting enough I don't know how to explain this. When you said you think the big problem is they're not getting enough calories, and that's why they're not able to, get into muscle anabolism. Like, it just seems like so many of them are overweight and obese. So getting enough calories doesn't seem like a problem for many of them.
Right. And so the thing is that there's even a person who's overweight and obese, if you put them in a negative energy balance, that will cause the metabolic changes. So there's been some really interesting underfeeding studies. And so I think, even if a person still had adequate nutrition stores, if they were in a negative energy state, even if it was slight, that could have an effect on but I agree. It's not, I don't want to say every single patient, it comes down to inadequate energy intake, but I think that is a much larger problem than patients not choosing high protein foods. Because most dietary survey studies show that hemodialysis patients consume a similar amount of protein as just general other people. It's just in terms of the percent of calories from protein. So it doesn't seem like and the thing is you say, okay, well, hemodialysis is a more severe state, right? So it's a more severe, so they're going to have more protein needs. Well, yes, but here's a kind of a funny thing. So dialysis removes protein, right? So that's one of the reasons why they have a higher protein intake requirement. But if I take a patient on thrice weekly dialysis and I put them on 6 times weekly dialysis, they actually have improvements in protein status. So they're losing more protein, but they actually end up healthier. They end up in better metabolic state. They have improved albumins. It doesn't matter what metric you're talking about, better anthropometrics. They tend to eat better. So I do think in that particular setting, I think that, how do we mimic more frequent dialysis? Well, we reduce the milieu. Well, how do you reduce the milieu? You make sure you don't overconsume on proteins in particular because of things like advanced glycation end products, gut-derived uremic toxins. Protein has a direct effect on insulin resistance. So it's really messing up the milieu if it's overconsumed. So, but again, that's that caveat. If it's the, and I'm mostly speaking to this idea that I think one of the things that happens is patients come in, they have a low albumin, and so they get thrown on a protein supplement. Well, you're making a very big assumption there in terms of putting everybody on a protein supplement, because that assumes that inadequate protein intake is the most important determinant. And in this particular case,
You're muted.
Apologies, Dr. St-Jules.
Sorry, did I mute myself the entire time there?
That was an error by myself. Apologies for that.
No problem. Did that answer sort of what I was thinking there? So obviously it does require an assessment. There are going to be cases where maybe somebody's not eating enough protein, but by and large, the dietary assessment data that I've seen does not support that theory. They seem to be eating fairly high protein diets, 16 to 20% of kcal, which is fairly, if they were consuming 30 to 35 kcals per day per kilogram body weight, they would be more than enough protein.
And I was just going to say, like, I think as dietitians, we're moving away from weight and BMI more and more because of sarcopenic obesity, because of fluid shifts that we are not always able to capture. And so I totally want to echo your statement of looking at the case as a whole and having a holistic approach to managing a person who is overweight or obese by our BMI standards, but is really undernourished and in negative nitrogen balance.
Mm-hmm. Yeah, no, and one of the questions that I think is really interesting is, at what stage of CKD do you no longer recommend weight loss? And you sort of say, okay, well, let's flip the conversation and let's start thinking about maybe weight loss might not be net beneficial in this particular patient, probably at the point where traditional obesity-related biomarkers are no longer predictive of CKD. So we do know that in advanced CKD, you have this reverse epidemiology thing where, you know, high cholesterol is no longer predictive of bad outcomes. All of a sudden it's associated with good outcomes. And so in that sort of situation, you know, that might be an example of a situation where, okay, well, maybe weight loss isn't always the go-to. And as I said, I think this is an interesting question. At what stage of CKD do you get worried about malnutrition instead of the negative consequences of overnutrition? Which I think is a really interesting one.
Jessie Colbeck had a question. She's hurt. I don't see her, but Jessie, are you there? Maybe we can come back to Jessie.
Yeah, so there's a question here about what is the goal of a pre-dialysis urea level. I don't actually have one specifically in my mind, and part of the reason is that I think there's a lot of uncertainty in terms of body size, residual renal function. I don't want to give sort of this is the right level, because it does reflect protein intake, and there's actually really good data showing urea recycling. So basically, if you put a person on, if they're not getting enough protein, as long as they're getting the essential amino acids, they can synthesize non-essential amino acids from blood urea and nitrogen. But I don't have a specific goal in mind, but I would look at that as a indicator of whether or not I thought they were consuming protein or not. And that would probably look at trends over time in particular, and sort of seeing if something sort of explains the recent change in terms of if there is evidence of malnutrition, if I was looking at the protein. But I don't have a specific blood urea nitrogen number that I specifically adhere to. I think it would be patient specific.
Okay, thank you. Jessie is with us now.
I can't hear Jessie though. I can see her.
Jessie, could you type your question? Can you type your question?
The sodium bicarb study, yes. Right, yes. So yeah, that is the presumption. And in fact, you would probably presume it would work even better. So the question is this study was based on supplementation with sodium bicarbonate. And the question is, well, what about an alkaline diet, which is a very hot topic right now? And an alkaline diet basically means limiting the amount of protein, particularly animal-based protein foods, and increasing plant foods, particularly fruits and vegetables, are thought to have a lot of those. What makes them alkaline is they have these organic acids with them. And so when they get metabolized, they can take on additional hydrogen. And what I would say is it's been clearly shown that fruits and vegetables can achieve the same reduction in blood bicarbonate levels as can a supplement. Supplement might be easier for certain patients versus others. Obviously, increasing fruit and vegetable intake is difficult. In this study, they actually delivered 2 to 4 servings of fruits and vegetables to their house on a weekly basis, like 2 to 4 cups a day. So they had fruits and vegetables. That's not exactly an easy intervention, I don't think. So it can be achieved. It can be achieved with diet, absolutely. And there's some suggestion that it may actually work better. Now, in terms of protein anabolism, not necessarily necessarily better, but I mean better in terms of patient health outcomes. So there was a follow-up study that just got published by Goraya, Goraya. It was a 5-year follow-up. It was published in the Journal of Renal Nutrition, and it was based on one of these studies where they fed them the fruits and vegetables or gave them the sodium bicarb. And what they found is that the eGFR curve was diminished in both the bicarb and the fruit and vegetables, but the fruit and vegetables appeared to have a lower hospitalization and cardiovascular disease rate over the 5-year follow-up. And so there was some suggestion that there may be some secondary benefits of the plant-based approach versus using a supplement. But I will say there's nothing wrong with the sodium bicarbonate supplement. Obviously, for some patients in whom increasing fruit and vegetable intake could be tricky or maybe difficult, that may be a very useful approach. It's more important to make sure that they're not acidotic. The downside is if you give them the supplement, then it almost like gives them free reign to liberalize their diet, and you won't know that they're adding all that acid load because it'll be masked by the bicarb supplements. So something to consider. But
Jesse just had a comment in addition to that, and I've seen this as well, the extra sodium when we give the sodium bicarb. I guess that would be one downside of of the medication.
Yeah, that's and there's some of that with potassium binders. Some potassium binders have the sodium as well. So there are some sodium loads that come from medications, and sodium bicarb would be another example. I will say in that particular study, the sodium bicarb was associated with good outcomes. It was done in stages 3 and 4. So it does appear to be net beneficial, even though, obviously if somebody had very uncontrolled blood pressure or really bad intradiabetic liquid, then maybe you might kind of hesitate. But in general, in those studies, they seem to be beneficial even despite the additional sodium load. Yeah.
Okay. I think we have time for one more question if anybody else has something they would like to ask. Okay. I did have one question. I don't know if you can answer it quickly or not, but as Janet mentioned, a lot of what you talked about today, I think, is practice changing. And I know in my own workplace, the dietitian is really expected to respond to high potassiums with a diet intervention of some kind. And, what would you suggest as a first step towards moving away from that model?
Yes, so that kind of touches on the etiology-based approach. And I think that this is the way that the field is moving. It's taking some time to get there, and but realistically, so if I had a person that came in and they got hyperkalemia, what I would do is I would start to think about, well, first thing I just want to get a general idea of their diet, the pattern, what does it look like? And then I would probably probe after some of the non-dietary determinants. What's their bicarb like? What's their stool output like? If there's no indication of any sort of, if they're doing something weird, they're doing something weird. So there's a lot of case studies published in the literature of people with hyperkalemia because they're eating, drinking 4 liters of coconut milk a day. And so obviously if something jumps out at you, you wouldn't ignore it. But most realistically, what I would recommend is trying to get the patient into a healthy eating pattern and getting them eating balanced meals if possible, in particular, because the main risk from dietary potassium does not appear to be accumulation. So it doesn't seem like potassium accumulates in the body the more you eat it, and then dialysis just lets you get rid of it. That's not really the way it works. It seems like potassium, the greatest risk is postprandial hyperkalemia. And so if I was worried about postprandial hyperkalemia, I would want the patient eating a moderate potassium diet. Fiber may help, physical activity may help. Those are sort of unproven therapies that are net beneficial usually. And then the reason why I'm thinking balanced meals, you're going to have some carb and protein to help with the insulin response to make sure that you activate those sodium potassium ATPases to get the potassium into the cells. The other reason why you have the balanced diets is if you're having a balanced meal, so balanced meal, 4 food groups represented, or if you're in Canada, I guess 3.5, because you have your fruits and vegetables as the 1 food group. But you want to have a good representation of food groups, because chances are if you're eating balanced meals, why do we tell people to eat balanced diets? Because we assume that means they won't get too much or not enough of specific nutrients. We know that when meals are balanced, that you might have a high potassium food in there, but you're probably going to have some non-high potassium foods as well, which are going to help balance it out. And as long as you're not having very large boluses of potassium, that shouldn't contribute to hyperkalemia. At least that would be sort of my thought. So my general approach would be, again, not thinking that it's potassium. They're not correlated. So if a person has high potassium pre-dialysis, that does not mean they have a high potassium diet. In fact, there's no association. Every study that's tried to find an association, except for one, which was questionable, has failed to find any link. So if you see somebody with high potassium, that means they have hyperkalemia. That doesn't mean they have a high potassium diet. So that's another thing to sort of keep in mind. It's not an indication of dietary potassium intake. If it was, it would be the potassium that they ate before the blood test. So if somebody's having like a cheat meal before they're going to get dialyzed so they can have a little extra potassium, they might end up with a high blood potassium because they went out and had some orange juice right before getting the blood test. And we do know that there's that postprandial rise. So that's another thing is you could have a hyperkalemia that's maybe nothing to worry about. Tell them just not have the orange juice next time right before they have their blood test. So that'd be another thing that I would be looking at and making sure you're not getting sort of a pseudo hyperkalemia going on. Does that sort of help?
Okay. That's a great answer. The immediacy
I'm on my
of
time here.
the intake. Okay, I think Eileen, I know you had one question. Nope. Okay. All right. David, thank you so much. You've given us a lot to think about, and I'm sure that as a group, we're going to come together and relook at how we do things here. So thank you very much. And please join us for the next session. So now Danny is up, and I'm so excited about this. I had a chance to listen to her presentation yesterday, and you guys are going to be wowed. You know, she's a pioneer in our community and a leader, but also, you know, bringing nutrition for kidney disease into the public realm, into the social media arena. So I think that's really something great that we can maybe all get involved with if you want. You know, she has a great enthusiasm for nutrition education and providing sound evidence-based information to the public. So I know when my colleagues and I have talked about photography and videos before, but you know, it's really how do you get started with it? And I think this is where Danny comes in today, and she's really going to provide us with some valuable information that she's gained through her experience. So Danny, I will let you have the microphone.
Thank you so much. I just want to thank you so much, Karen, and thank you, Eileen, for organizing this breakout session. Thank you, Charles, and thank you, David, for your amazing presentation. I learned so much. I just want to acknowledge that I'm presenting to you from home on the lands of the Squamish, Salish, and Tsleil-Waututh First Nations, and it's a real pleasure to be here. You know that I love what I do, and you know that I just love being part of our provincial renal group. So I'm very grateful to have you here today. And I really do hope you jump in with your thoughts and ideas. And like always, I get nervous a bit when I'm presenting because I'm always talking about new things, and I feel like sometimes I rock the boat a bit, but I think this now more than ever is a good time to rock our boats and just kind of think differently about how we practice, not only to make a difference for our patients, but also to make a difference for ourselves. So hopefully this will help you. I'll just share my screen here. Is that working okay? Great, thank you. So yeah, I think we're a brand. Dietitians are a brand. How do we utilize social media and become a digital source of trusted nutrition information? So before I go on with my presentation, I'm just wondering if we could do our first poll question. So please take a minute and just pop in your answer to the following. How confident would you be if asked to make a nutrition video for social media as a professional, as a dietitian? Okay, so it looks like about 56% of you would say not at all confident or would say no, uncomfortable but would do it anyway, 38%, and confident would jump at this opportunity, 6%. So if we look at, just under 50% of you would do it. So we've got potential here. And so I hope this presentation will shift the dial And not to, again, as Karen mentioned, it's not to force you to shift the dial, but it's just going to be really interesting to see how you might change your perspective after we have a conversation about it. Thank you. So I'll just close the poll and I'll move on. So I think even though you're not ready to make a nutrition video quite yet, you're here today because you're interested, you're keen to learn more about how social media can help you disseminate your nutrition message. You are a person who's willing to take risks. You've worked through the last 8 months of incredible change in our field and how we practice. And you've shifted, you've moved into that with great confidence and support to your patients. So you are taking risks as you're moving forward in your profession. You have confidence in yourself that you are a professional, that you are the trusted source of information, and you can share that information with a larger audience. And you're an innovator. We're all innovators in dietetic practice because dietetic practice is always changing. And right now, our biggest handle is really technology. And I was so surprised to find these statistics through the Canadian Communications Monitoring Report. Most people are basically ditching their landline and opting for a mobile device. So the growth is even greater than what it was about 5 years ago. Most people have an internet connection and most people have a mobile device. So it's pretty interesting to see that. Even from a testimonial perspective, some of my patients who don't have the greatest financial security still do have a cell phone if they have CKD. They know that with a health condition, they need to have access to their care provider. And now moving to a virtual realm, more and more realizing that they need to learn to engage with us on a virtual platform. So this type of device use is growing. Okay, so there is a burden of chronic kidney disease, and how does social media play into that? Across Canada, about 13% of people are impacted with CKD and about 4 million persons affected. Increasingly, our CKD population is going to be younger. They're going to be searching for information online. So even if the parent is the person with CKD, their children want access to online information. TV is on the sort of the downspin, but YouTube and other ways of engaging with social media are on a rise. So people want to stream information whenever they are ready to hear it or listen to it. It's very important that we as dietitians have some kind of competency of social media, even if you don't want to make your own videos, that you know what Facebook groups are out there, that you know what dietitians are doing out there on social media. And I think we need to really kind of take this concept of I don't do social media and turn it on its head, because if you don't do social media in the next 5 years, you might be missing a large amount of information that's valuable to your practice, that's valuable to your patients. So I guess now we'll go into our second poll question. What are some of the barriers that you think you're facing as we think about this topic of making videos for social media? Is it I don't have extra time? Is it my kitchen isn't set up for it? Is it I need special props? Or is it I don't know how to present myself? Okay, so we've got about a 72 response rate. Perfect. So really time is your biggest barrier. Well, what if I was going to share with you that you can just do a video in less than 5 minutes if you wanted to? So maybe I can help you break down that barrier today. If you don't know how to set up your kitchen or how to present yourself, I have some ideas as well to get you started. So, so that's great. And if you think you need special props, I'm really excited to hear more about your ideas around what those look like. But I use basic things I have in my house. So you sound like you're a creative person. I want to hear more from you. Okay, great. Oops, sorry. So what are some of the actual legitimate barriers to dietitians in the social media? Yes, absolutely. There are legal ramifications. And so definitely number one is that you require extra liability insurance. I have mine through Dietitians of Canada, which means that I'm covered 24/7 for my legal needs. And so it's really important to make sure you have that. Your workplace covers you for your work-related activities, but if you want to do other things, it's really important to get that liability insurance. DC has just lowered their fees as well, so it's quite reasonable to buy liability insurance. You're covered for quite a bit. It's really important to mention any disclosures you have. So if you are trying to use ingredients that are from a specific company, you need to disclose that you're doing that on their behalf. So that's really important. And obviously you need your registration up to date, and obviously you need to work within your practice scope. What I think is so great about our group is that we are dietitians who are specialized in renal care. And so we can stamp that. We're experts in our own area. We're not touting that we're, dietitians in a certain scope that we're not comfortable with. If you have time constraints, definitely it's going to be much harder for you to pop in making a video. But what I suggest doing is really planning ahead and giving yourself time either outside of your schedule or within your workday, if that's allotted, to plan and get your materials in order, and then one day to do your video, so that you're not feeling like you're doing it all in one day. But I think time constraints can be worked upon if you're just kind of planning ahead. So we can dialogue about that. And yeah, of course, a big barrier is I don't really feel comfortable using the media. And I don't know what to do, how to get started. So there's lots out there on the topic. And if you just take the time to either join the Dietitians Facebook group, there are always opportunities for learning through the Dietitians groups. And you can let me know if you have questions about that. So really, I think there's so much more benefit. There are barriers, but the benefits of being on social media as a dietitian, number one, is cost effectiveness. Rather than telling each patient about a practice point around, say, how to lower their uric acid, why not make a little video clip about that so you can share that with your patients rather than regurgitating the same message? Why not do a brief cooking video on a vegetarian recipe that you enjoy preparing at home and you were going to do for dinner anyway? So if you hit two birds with one stone like that, this can be a really cost-effective way. And if we use professional platforms like BC Renal or the Kidney Foundation to post our videos, then that will reach a huge audience. It will also allow us to collaborate on an international level. If we put ourselves out there, people will want to talk to us, and that invites mutual learning and mutual benefit. You can practice, do knowledge sharing on a much wider platform. You are a fountain of information, but if you're just working within your office, it's very hard for the rest of us to know how amazing you are. So by putting yourself out there, you're showcasing your greatness to not just yourself, but to everyone. So I think it can be an efficient communication strategy as well. We can package a message beautifully that can reach a larger audience. So obviously, I'm a proponent of this. Again, there's evidence, scientific evidence that social media has been an effective tool for virtual nutrition counseling, for patient education, for peer-to-peer support, and public health campaigns. It basically covers the gamut of what we offer in healthcare. And so again, partnering with platforms that are professional platforms can really help expand our messaging. As of, just within the last month, our cooking videos that Tanya and Bev made a number of years ago have had over 100,000 views alone on the BC Renal website. And you might say, well, it was just me viewing the video. So that was me viewing the video 30 times, 40 times. Yes, but you did go and view that video 40 times. Why did you do that? Why did it matter to you? So I think that it's still really valuable to consider this as an option. Okay, so now here's to, I don't feel comfortable being in front of a camera. I'm just not comfortable enough. I feel worried. Your goal is not to be this supermodel, super have it together dietitian on the camera. Your goal is not to have influencers. Your goal is to be the trusted source of nutrition information. You don't have to have the beautiful dishes or presentation platters courtesy of Martha Stewart. You can just work with what you've got at home. You don't have to have makeup on. You can wear a t-shirt. It's totally okay. People care about you because they care about the message that you have, and they know that your message is truthful and based on sound evidence. You can use your current platforms to practice. If you have a Facebook account, you don't want it to be anything more than just sharing that with your friends and family. Why not do a small clip? Why not do an Instagram clip of something that you're passionate about? You can even have a private YouTube channel that no one sees. If you just want to practice, that's okay. And of course, you can tweet out the links to all your beautiful videos through Twitter. So, you know, unleash your creativity, do it in a healthy way using technology. It's amazing in terms of what you can achieve. So I also am very fascinated about where the public get their health information. And I couldn't believe that 71% of people go to Facebook and YouTube, and they even go a little bit on Instagram and Twitter. And this is from Forbes. They're not going to scientific papers. They're not going to the right place. They're not going to the right websites. They're going to Facebook. So this is, you know, I think an opportunity. I mean, it's detrimental that people are seeking this information out for sure, but it's also an opportunity for us to come in and be like, here's a, you know, reputable group of people giving you a reputable message. Okay, so here's the Zoom negativity, right? Like how many people turn their cameras off? You know, oh my gosh, look, I'm sorry for my COVID hairstyle. I'm not going to have my camera on. You know, I don't do Zoom. I don't want to be seen on camera. If you judge yourself and you let others judge you, you're depriving yourself of your full potential to help and heal and benefit others. You're an amazing attribute to our system. You are valuable. And even though you don't have your hair done, it's okay. You're still a contributor. Turn your camera on. It's a great way to practice your speaking skills. It's a great way to practice your facial expressions. When I was in high school, I had trouble speaking, and I would use the words and like all the time and use slang. And one of my teachers said, you know, you've got some good things to say, but the way that you talk makes you sound like you don't know what you're saying. So, you know, back then, that's the kind of feedback students got. So, so he said, you should join Toastmasters and just learn to speak in front of people. It changed my life. It was huge for me. So make Zoom your Toastmaster opportunity. Even if you're having an informal meeting, you know, try to just channel that inner confidence and just speak up. Say what you feel, give your opinion. So important. So there's a thesis paper that was that I found online, which was so amazing because it's talking about social media within the framework of dietetic practice. So when you look at this, it just resonated with me so much because as dietitians, really the essence of what we do is that we have a specific identity, we have a presence, we build relationships, we share information, we dialogue, we're in conversations, we're part of groups, and we really care about our reputation as professionals. So all of this can be translated into data and technology. And so we're closer than we think, which I think is so validating to kind of what I'm trying to do and what I think some of us really want to strive for as well. So I guess going to my next poll question, please. If I may. Great, thank you. So please answer the following question. What topic would you like to make a video about? A renal diet related topic, a cooking video, or a shopping video? Okay, great. So Perfect. So about 46% of you want to do a shopping video. Well, I'll tell you that that would probably be the most time-consuming one of all. So it's amazing that you're saying time constraints are a factor. Maybe your bar, you know, let's lower it like quite a bit and just be like, I want to talk about an ingredient in my house that's kidney friendly, that can be built into recipes, right? Now you've suddenly lowered the bar. Maybe the time constraints aren't a factor anymore. I would love to see a shopping video. That would be great, but that would entail a lot of layers. And so at this point in time, I would say if you're going to do a shopping video, you'd have to think about a way to do it at home. So that may become a bit more challenging. A cooking video is also really great, really easy to do at home. So that would definitely, it would take you a bit more time than a renal diet related topic, but it's certainly doable with simple ingredients. Great. When I sort of think about what I want to do in terms of creating a video for my dietetic practice, I usually start the way that you just did. I think about what do I want to talk about? And really that comes from my dialogue with the patients. So if I talk to a number of patients about a topic like say hydration, because I work in pre-dialysis, then I might think about, well, how do I engage my patient in drinking more water? And I start to piece together a sketchboard of what I might do for my video. Okay, so I need to get them to drink more water. They say water is boring. What's a healthy way to flavor water? Okay, how about a fruit infused water? So I might do that. So then I just set that up and I basically, you know, do the video and I post it on social media. And then I see kind of what comes back. And it's amazing the feedback that you get from people of, oh, I never thought of doing this. And you think to yourself, this is like the simplest thing you could do, but for people it's news. And so never underestimate the power of your message. It can be huge. And when you measure that reaction, people might even give you extra feedback, like next time, can you feature a recipe with dates or coconuts or something, high potassium, because my potassium's low. So, you know, it can engage people in wanting to hear more from you. So how did I get into this? I guess I should let you know. I've been part of sort of doing media, doing my own blog, being on Facebook for a while. And I really, because I did my master's in statistics, I learned how to code. So I was really into coding. And by 2010, WordPress was taking off. And so that taught me a lot about how to code for a website. And so comparatively to that, doing a video is so much easier than doing a website. And now websites aren't really as frequently visited as a video might be looked at. So I also participated in doing videos for CBC, Breakfast Television, and Kidney Foundation. Luckily, I work with a team of dietitians at St. Paul's who are also really interested in media. So we were able to contribute some videos to the BC Renal platform. So since COVID-19, unfortunately, I'm working from home, so I'm disconnected from my immediate team. And physically, of course, we're on Zoom. So I had to sort of shift how I was doing things and record videos from home. And some of those videos are on the National Kidney Foundation website. I did notice since the start of COVID that a lot of people are going to social media for their health information, and a lot of posts aren't by dietitians. So I started to look for dietitians who are posting on Instagram, who are on Facebook, and just looked at the types of things that they were doing. And then I just bought myself the basic equipment. So I actually have it right here. It's just a stand with a light around it. So I basically have lighting and my stand for my iPhone built in, and it just plugs in. And this was about $100 at London Drugs that I decided to invest. And then I went online and looked at tutorials on what others were doing in terms of making videos and how to make it easy on myself. And again, my springboard for questions and topics to do videos on really comes from my work with my patients. So as I already alluded to, I'm a one-woman show, so I just create my storyboards. I try to use containers I have at home, so I have these clear bowls to show the ingredients. That's really important. People really like the visual, but I would say people don't really like clutter. So if your background is kind of cluttered, you may want to move things out of your camera shot, because then people's eye is drawn to the things that you don't want them to focus on, because you want them to focus on the ingredients. I would say have a finished product to show, and then maybe do a bit of minor cooking, unless you're demonstrating a technique, because no one really wants to kind of watch the dietitian sort of move the spoon around for 5 minutes, right? Just trying to heat up the food. So have a finished product ready to go, and then just showcase, you know, your key ingredient. In this case, I was doing a piece on tofu and vegetarian eating, so I was talking more about that. You can just use your phone to do simple editing, and I really try to keep my videos short so I don't have to do a lot of editing, which also saves me a ton of time. When you have to move from camera shot to camera shot, then you need a media person, but it may not be necessary if you really ask yourself whether you need the really beautiful camera angles to convey your nutrition message. The lighting is really important. Here, I wanted to show you this picture because I actually had the wrong camera angle. Ironically, my sister, who did a degree in media and communications, filmed this, and she failed to turn the camera sideways. So I blame her. But at the end of the day, you want your phone to be sort of like this way instead of this way at the end of the day, so that on YouTube and on the media, you don't have these black bars beside it. I would use simple, you know, wear simple colors, nothing too dramatic, no flutter sleeves that can catch fire, you know, just your simple clothing, your dietitian wear from work, no problem. Whatever you've got is fine. Try to look natural, look like yourself. If someone was going to visit you in clinic, you know, that's a great look for you to have. You don't have to try to spend time, right, on those things. And then just budget for the ingredients you have at home. Again, that's a time saver. You're not going out to buy the ingredients for this obscure recipe that probably your patients won't benefit from either if they have to go hunting for ingredients they don't have in their pantry or fridge. So is there time for me to just show these videos, or can I go ahead? This was one that is that okay, Karen? Sorry,
I'm muted. Yes, yeah, it's just 1:13, so we have time. Please go ahead.
Okay, yeah. So thank you. So this was just a simple breakfast burrito recipe that I did for the Kidney Foundation. I used their recipe, and this was for the Kidney Walk 2020, which was virtual. Hello, my name is Dani Renouf, and I'm a registered dietitian. It's a pleasure to be here with you today to share with you one of my favorite breakfast recipes, the breakfast burrito. Breakfast burritos are a great way to start your day because they're made with one of my favorite ingredients, eggs. So with 2 eggs, which I'm going to scramble in a heated pan, you will likely get adequate amounts of protein for that meal. And so it's a really great way to start your morning. So once the eggs are fried up, or starting to set, I'll add some red peppers. I love red peppers because they're loaded with fiber and vitamin C, but they also add a great deal of flavor to whatever I'm making. What the peppers do as they heat up is they give a sweetness to the egg. And so if you prefer something spicier, you can certainly use chili peppers or any other sort of pepper that's got a bit more kick to it. Finally, to help season the burrito, I'll add some dried spice mix that I've blended. So I've just used pepper flakes, some dried basil, dried oregano, and just some Italian seasoning together. So while that's kind of setting, I'll just grab a spoon and I'll just sort of remove the egg from the sides of the pan. And I'll scramble it all up together. I've got here a whole grain wrap. I chose whole grains because they impart more fiber to the diet. So again, this is a great way to start your morning. And this particular brand does have a lower sodium content, so just make sure you're label reading for % sodium when you're buying a wrap. Choose the smaller size wrap if possible, and try to aim for less than 15% sodium per wrap. So once my beautiful egg mixture has set and cooked thoroughly, because we want to make sure the egg is cooked all the way through, I'll just put half the mixture into my wrap. And wraps are a bit easier to fold if you just microwave them for about 15 seconds, or if you use another heated pan just to heat them up slightly, then they're more likely to bend and help you put together your beautiful wrap. So once I've done that, rolled up the sides, I've got a beautiful breakfast burrito ready to go in seconds, really. And it's a great way to start your day for protein, for fiber, for vitamins, and for a low sodium, delicious option. I hope you enjoyed this recipe, and I hope that you will visit the Kidney Community Kitchen website for more recipe ideas.
Okay, great. So that was one of them. And then this is just another viewing of basically like a quick nutrition video that you might want to do. So kind of a time-saving one. This literally took me just a few minutes to do.
Hello, my name is Danny, and I'm a registered dietitian. I'm just going to share one of my favorite hacks for trying to get more water into your day. Many of us and many of my clients just don't seem to get enough water. And if you have a kidney condition or other health conditions that require you to stay well hydrated, it's really important to try to find ways to do so, especially as we move into the colder months when we may not feel as thirsty. So this is a nice, simple way that I do a water infusion with fresh fruit. Not only do I get my water, I also get fresh fruit into my day, which is another thing that I often find people lack. So here I've just cut into half a mandarin. I've got mint, which I grew in my garden, so that was fun, and some frozen berries and pomegranate pieces. So I'll just put that into my beautiful water container here, and then I'll just add water. Here I've got my beautiful, colorful, perfect infusion of water and fruit. So this way, I make sure I get both. I hope you'll try this. It literally takes seconds, and it's a great way to take care of you.
Great. So, so these are some steps then that, you know, you might want to consider if any of this was interesting to you. And it might start with just joining a dietitian group on Facebook based on your interest and practice area, maybe even creating your own account, even if you don't use it, just getting into something, a type of social media. A great place to start, and I see a lot of dietitians doing this, is to post an article that is scientifically reputable on Twitter. And so, you know, just even tweeting out the latest research or the Kadoki guidelines or whatever, you know, you start to sort of engage with other people who are interested in the same thing. So even if you want to keep it professional to professional, that's a great way to do it. And also learning from other dietitians who are already quite versed on Instagram. And I've been doing that. I've been following some really amazing work of dietitians out there, and it's opened up a lot of learning opportunities for me. So that's been a great benefit. Yeah, so are you ready to make your own videos? It would be great to maybe find out, you know, you are here as a professional, the media is here, you know, the public is waiting for you. How do you feel about aligning all these things that eventually are going to be part of what we do? Are you going to watch videos? Are you going to check out other vloggers, find out what they're doing, even though they're not in healthcare or know anything about nutrition, but have a great media presence? Are you going to practice? What's it going to look like for you? So these are really probably great questions to ask yourself. And maybe we'll post our question again, Charles, that we had at the beginning of our session. After sort of spending this time together, how confident would you feel on making a nutrition video now for social media? After watching me, I know you can do better. I challenge you. Yay. I love that you're uncomfortable. We're always uncomfortable, but that's a great place to be. And I love the confidence that's going up as well. And if you're still not confident, that's okay. You're still doing amazing work. And this isn't something that you necessarily want to do, but maybe now you'll be looking at, you know, others doing this work and support their work, which is also incredibly valuable. When I see a dietitian reaching out to me and saying, really enjoyed watching that video, it's just like the best compliment I can get. So it helps support what I do. So I'm thrilled. I feel this is great. I hope to see you all on the social media, you know, realm, and in however you want to be involved. And I'm just really grateful that you will consider it. So the last slide really I have is, you know, obviously our questions and comments time, which I look forward to. But I was just literally searching dietitian and professional and technology, and basically the dietetics website from UBC came up, and this is what their image is for the future of our dietetic practice. So this is how they're training their students. So even though, you know, we're not that group, our students are. And so I think it's really good food for thought, I guess, as I wrap and invite you to share your ideas with me. Thank you.
Thank you, Dani. I would like to get right to the questions. Oh, I see Eileen with her hand up. Oh, but she has no audio, or she's clapping.
It's not my enough. I was just clapping. It was wonderful.
Thank you so much. Thank you. That's so nice. Oh, I love this. I turned my camera off because I'm eating lunch. That's okay. I'm just looking at the comments. Really nice comments.
Dani, I loved how the poll showed the increased level of confidence too. It's like all these people ready to just jump off and start making videos.
I knew it. I knew it was in us. I know it's in us to do this. I'm just so excited for our future. Like, I know this is a challenging time. I know there's lots going on for people. So the fact that people are open to this makes me just have so much hope. And so I'm really, really excited. I have some questions here. Should I, they're coming through rather rapidly. Should I
I can read them out for you. Janet says, thank you so much.
Thank you. That's so nice.
And then Jessie has, she's wondering, do you have 2 Instagram accounts, one for family and one for all this stuff, and the same for Facebook?
That's great. I don't have a separate account right now, but I think I'm moving towards that because things are really taking off. I initially used my personal account just with my own friends and family. I actually have a few dietitian friends on that Facebook account as well. So I started doing that, but now I'm realizing how much potential this has. And so I would like to separate out my private account and do a more professional account. Then there's a good question of how do you want to brand that? How's that going to look? And Karen and I talked a bit about that yesterday. So I guess that's where I'm at, is like, how do I brand this? How do I want this to look? And so I need to do a bit more research on that, because right now, anything I do as a dietitian is for Kidney Foundation and BC Renal. So I've been using their platforms, but now because I'm home, I'm just wondering what the best platform will be. And I totally think having a separate platform is really necessary for that. Yeah. I also really liked, there was one question. Okay, sorry. There was a question. Oh, do you have a Twitter account or follow someone on Twitter? Same thing with Instagram. Yes, I have a Twitter account and I follow people on both Instagram and Twitter. So I have both accounts. I'm very comfortable to share my account. It's just Dani Renoff. So
you know, even with my Facebook, I'm very comfortable to share that information with any of you. If you want to just go ahead and have a look at things, I can also send you my YouTube link. So just reach out to me if you want to see more of my videos. I do have my kids on some of the videos as well. So, and I'm happy for people to see that. So I'm totally okay at this point. So.
Danny, you and I talked about this question yesterday, but other people might wonder. When you have a social media account coming up with a name, I know there's a lot of sort of clever, catchy catchphrase names out there, but what would you suggest for naming your account?
Yeah, and I mean, this is kind of more my personal opinion and observations I've had, but dietitians who have their own private practice and they have sort of like a very catchy name that doesn't have the word dietitian in it, they've rebranded a lot of them to include the word dietitian or include their full name. I think that's really important. You are the brand, right? And dietitian is the brand. And so if you're doing something, please, first and foremost, put that dietitian term in there somewhere, even as a secondary line, and put your full name. That's really, really important because people do search your name and they look up to see if you're legit, for example, or what college you're registered under or whatever. So that's really, really important. That's what we want, is, you know, every video you do, introduce yourself as, hi, my name is, I'm a registered dietitian, you know, this is my area of practice or whatever. It's really important to promote that when you're doing your video and your branding. I guess, yeah, there were.
Hi, I'm not seeing the questions. They might be sending them to you privately.
Oh, it could be, yeah. Okay, so do I need extra insurance if producing work-related videos for just my own patients? Okay, great question. What we did for all of our videos that we did, you know, for PHC is we talked to communications and we worked with the media people. So I would definitely encourage you to reach out to your respective communications department for instruction before you move forward. That's really a great question. But they'll be able to guide you and provide you with support. Great. I think did we capture everyone? Oh, vehicle video syndrome for a laugh about this topic. Okay, I'll do that. I don't know. Someone give me a tip, so that's good. I'll follow up on that.
I think if we need a laugh from COVID or the election, that might be a good video to watch. Okay, Danny, thank you so much. You've provided us so many great ideas for moving forward with our social media presence. So thank you for doing that. Like the presentation, I know must have taken so much preparation. I would like to say thank you to Danny and Dr. David St-Jules. I think that he may have left us today, but I'm really happy about today, and I hope that you all are too. We had at least 44 participants, so that's way more than we would get at an in-person meeting. So that is really terrific. And I would also like to say thank you to Charles for making this happen, because he is a Zoom expert and I am not. So thank you so much.
No problem. Thank you very much.
Thanks, everyone.
Okay, see you guys tomorrow, I hope, online. Bye.
Bye.
Bye.